So welcome everyone. Today's webinar on clinical testing based on data-driven practices with ACL rehab. I think obviously personally and professionally, I think this is an incredibly valuable topic with and without sort of Kinvent, but in general in rehabilitation, so much of our profession was quote unquote evidence-based. But where that evidence comes from, and the sources for that evidence remain a question. So, really getting actual data to drive clinical decision making, in my opinion, is sometimes even more important than looking at sort of paper reviews and things like that, because we sometimes don't know where some of those reviews are coming from. So, with us today is Dr. Wesley Wang, who's a physical therapist located in Maryland. He's earned his Doctor of Physical Therapy degree from Franklin Pierce University in 2015. Wesley currently specializes in ACL rehabilitation, as approximately 70% of his patients are ACL patients, with the majority being high school and college athletes. Wesley has also been fortunate enough to grow a social media following that utilizes his platform to teach people about how to properly rehab ACLs, and believes that ACL re-tear rates are significantly too high, mostly potentially stemming from poor quality of care and poor return to sport testing. So we've got a good group with us today, over 60 people. So yeah, if everybody can sort of shout out where they're from, I think we'll actually put a poll up just to see where all over the world folks are at. It'd be kind of interesting to see. So we'll give you guys a second to answer that. Awesome. So actually, this might be the first time for me that we have a US-based therapist, with the majority of our folks actually from Asia and Europe, which is actually really cool to see. So Wesley, take it away.
Cool. Appreciate you having me, Alex, and for Kinvent for just hosting this opportunity. And yeah, we're going to dive into, for me, something that's really personal for me. I'll kind of share my story and also why it's so important for me, and then dive into the research as well, which is sort of, I think, important in grasping sort of, in my opinion, the highest quality of return to sport, which is still something that is a little bit misunderstood. So we'll kind of get into that a little bit. So yeah, just a little bit of background about me. My name is Wesley, and I am the clinic director of Healthy Baller in Rockville, Maryland. I'm a two-time ACL tear, which is why it's so personal for me. I sort of committed my career at this point in helping educate others on how to properly rehab ACL from start to finish, which I feel like is extremely mismanaged in our professions. And at the end of the day, my primary goal today is to have you guys learn through this webinar, just leave today with a better understanding of the research and why return to sport testing is so pivotal. Just so back again, just to reiterate, as Alex mentioned, approximately 70% of my patients are ACLs. And again, most of them are high school and collegiate level athletes. I've personally just seen the mental and the physical toll that it takes on people. And again, I've experienced it myself. It's why it's personal for me. In my opinion, I think ACL rehab is extremely challenging, and it's also extremely complex. I think especially in the outpatient world, it's probably one of the hardest injuries that we treat. Obviously, I'm excluding things like strokes and brain injuries and things of that nature, but in the outpatient world, this is one of the most complex injuries. But our profession, unfortunately, treats it as if it's just a cranial ankle sprain most of the time. And my dream philosophy, whenever I get anyone, my saying is that we have the right way the first time, because of how high rates are, which we'll dive into in a little bit. So right here, approximately 150,000 ACL tears occur in the United States each year, and I think this number would be as high as 200 and 250,000 a year. And I say that tearing your ACL once sucks, and tearing your ACL twice really sucks. And again, I'm in that boat of tearing it twice. And as Alex alluded to, I think my opinion on this is the fact that the reason why re-tear rates are so high is because of improper care. So approximately 20 to 35% of patients suffer a second ACL tear. So if you think about 1 in every 4 to 5 people are suffering a second ACL tear, and you think about the magnitude of that injury already at the first time, and what it's going to do to someone the second time around, and I think at that point people even start losing track of what happens after that, because there are people who re-tear it a third time. And I think for most people who do it 3 times, their athletic careers are sort of over at that point. Again, this is why my whole philosophy is let's rehab right away the first time. And I think, in my opinion, people don't ask the right questions as to why second ACL re-tear rates are so high. People sort of just accept it, that's the norm, and they just choose to accept it, that's the reality of people who suffer an ACL tear, and that if you're part of that 20 to 30%, that's just bad luck, unfortunately. And again, I don't think that people are asking the right questions why. And as that box sort of says, improper care, in my opinion, is a primary culprit to high second ACL tear rates. I think that in our profession, we don't really receive formal education for ACL rehab. They sort of, you might get some experience on your rotations and things of that nature, but at the end of the day, if you suffer an ACL tear and you go to physical therapy or physio, and you could be the first ACL that this person has ever treated from start to finish, and with no background knowledge or no mentorship, that's you who's suffering as a patient. And unfortunately, this is the reality a lot of the time. And an improper care includes a poor understanding of ACL rehab. This starts from day one. This starts from prehab all the way to return to sport, which is sort of the big stuff that we'll kind of dive into. A poor understanding of basic conditioning. Again, I don't know. I can only speak of what it's like in the United States, but in the United States, in PT schools, they don't really give you a lot of information about strength conditioning, which I feel like is arguably the most important thing that we're doing across the whole spectrum of ACL rehab. At the end of the day, we're trying to get that ACL leg symmetrical to the non-ACL side. I think another thing is utilizing outdated protocols. I've worked in 2 different facilities where we're owned by physicians who did ACL surgeries. We were told, especially as new grads, to sort of follow their protocols. And a lot of these protocols are extremely outdated. They still say information. Like patients should go back at 6 months or 7 months. No real education on how to properly test patients, and again, no real guidelines as to how to get from point A to point B all the way to point whatever Z, which is the end of returning to sport. The last 2, improper facilities to return to allow patients to return fully to sport, which I think is extremely important. For example, my last job, the heaviest dumbbell we had was 10 pounds. The heaviest kettlebell we had was 15 pounds. We had no space to do any type of running, cutting, change of direction, or anything like that. So in my opinion, those type of settings, which are very, very common, have no business returning people back to sports because they have no means to do that. And that's not a spite towards them. That's just the nature of how our rehab settings are. So they should be affiliated with a local gym or local sports physical therapy facility that is able to get them to the rest of the way. Because I think a lot of facilities are equipped to get them back to jogging and things of that nature, but that doesn't include the sprinting, the aggressive plyos, the change of directions, and ultimately return to sport, which is what's important.
Wesley,
and the last thing, sorry, go ahead.
Direct for a second. I think one of the things, and also based on the poll that we're kind of seeing, right, is this non-understanding of why we re-tear. But does that, in your opinion, potentially come from the fact that we aren't actually even measuring how we rehab, right? We kind of go off of this mythical protocol guideline, whatever you want to call it, but it doesn't actually check the person on how they're doing, what are they doing, how are they going through this? Because then if we're not checking what we're doing as we go, then we can't measure it against anything going forward. Because if they re-tear, that's the culmination of a million different data points that occur, from the surgical, the portals to the anchors, all the way through to, depth drop jumps and T drills and everything else, right? So along the way, where did that person go wrong? Saying they went back too early, potentially, it's a lazy opinion, right? So I think, to your point, I'm sorry for cutting you off, but I think that's one of the things I wanted to see just in the beginning, whether you have a take on that, and whether it's that we are doing it wrong, or we're not even measuring what we're doing to know whether it's right or wrong.
Yeah, that's a really, really great point. I think it's a combination of all of that. I think that some facilities don't even have the ability to test, and on the flip side, a lot of clinicians don't even understand what the testing even looks like. So it's a sort of double-edged sword, which I think is contributing to, again, why these re-tear rates are so high. At the end of the day, and we'll get into the research in a little bit, the primary goal is that most research supports that you should be within 90% strength, power, function on the ACL compared to the non-ACL side. And some clinicians, myself included, are pushing 95 and above to try and really get that as close as possible. That's obviously one of the big factors. I think strength-wise is probably the biggest thing that a lot of facilities don't have the ability to test, whether it's lack of equipment or knowledge or whatever it may be. That is probably, I would say, one of the main culprits. And there was a study a little while ago, I don't have it off the top of my head, but they polled physical therapists in the United States and asked them sort of how they objectively measure strength in patients. And I think something absurd, like 55% of physical therapists are still utilizing manual muscle testing to what they deem as objectively measure a patient's strength, in which we know there's so much subjectivity that goes into that is a really, really, really poor way of measuring, which is why facilities need to invest in proper equipment in order to properly test. And something else that you brought up also is the fact that they should be tested throughout the entire time. It's not just like you're waiting until 8, 9, 10 months and then you test and then you're not good and then what do you do from there? Some people test as early as 3 months, some people wait until 4 or 5 months. But I'm really big on testing in that early to middle phase, 3, 4 months-ish, and starting to track them throughout the entire course of the rest of the rehab. The data should drive the decisions you make in the weight room, essentially. If their hamstrings are testing really, really well, then not to say you should neglect hamstrings, but that means that maybe your priorities should shift a little bit more to quads, and vice versa. If the quads are testing really well and they had a hamstring graft and the hamstrings are extremely weak, you might need to put a little bit more time into the hamstrings. Obviously, there's rate of development, which is extremely important as well. But I think that's where the testing is really, really important, is that you test and then you sort of allow it to dictate your rehab programming, and then you retest to make sure that essentially your programming is doing what you need it to do. And let's say theoretically you go 3 weeks and you retest and nothing really changes. The numbers are sort of the same. You as a clinician need to sort of reevaluate, what am I doing wrong? What am I missing? Are there external stresses that are going on too? Because at the end of the day, these people, they're real people. They have stresses in their life. There's things that are going on at home that can affect how they're rehabbing. Sleep. There's so many factors that come into play. But again, that's where I feel like the data and the testing really comes into play.
Yeah, I agree. One other thing, Wesley, if you could, there's a little bit of a glitch on your sound. Can you just slow down speaking just to see if that helps a little bit?
Sure.
Thank you.
Okay. As a healthcare provider, again, PTs, physios, we have athletic trainers in the United States that help with rehab, even strength coaches in that late phase. They're not healthcare providers, but they're still providing some sort of care towards the end. The healthcare providers have a massive, massive impact and can be the difference, in my opinion, between our athletes not becoming a part of that high statistic. And this is where the knowledge and the ability to rehab really come into play as far as getting athletes all the way back to sports. I'm just going to dive a little bit into my why. I won't spend too much time on this. But so, I emphasize that most of my kids are high school and college level athletes. So suffering ACL tear, especially for someone of that age, is likely one of the most impactful events of their lives. Our roles as a rehab specialist is especially important in the recovery process because we are the ones spending the time with them rehabbing. You think about the surgeon. A lot of times, the surgeon does a surgery, and then they'll see the surgeon at 2 weeks, 6 weeks, 12 weeks, and these appointments are 10 minutes long. Our sessions are an hour, multiple times a week, and we're seeing them for weeks on end, and we're the one developing a relationship with them and seeing them getting stronger. We are the primary people that are making a difference for their rehab and also ultimately their return to work. Again, proper rehab can be the difference between one surgery and returning back to a normal lifestyle versus multiple surgeries. Think about people like high school athletes losing a scholarship or losing out in their community because they're the ones who are on the sidelines getting hurt. Maybe they're too depressed to go to games or practices and things of that nature. There's so many factors, psychological and physical, that come into the play for rehab ACLs. I want to share a little bit about some of my patients in the past. And again, this is why testing is so important. This is a real patient of mine. Thankfully, she's graduating now. But this was her in college. This is a 20-year-old lacrosse player who was cleared for full return to sport by her college athletic trainer, despite not passing all of her tests. This is coming off an ACL tear. She was roughly, I think, 11 months post-op by the time her 10 to 11 months by the time her first game started, she was coming back from an ACL and a meniscus repair, which no meniscus repair will slow down the overall spectrum of rehab because of how slow the early phase is. And I know it's a little hard to see the numbers right there, but I can show them to you. So this is the Biodex, which is still considered the gold standard for testing. The majority of the people, I don't know about Alex's experience, but I do not have a Biodex at my facility. So you have to figure out essentially different ways to test them. But this young lady, unfortunately, did have the ability to test. So I know the numbers are a little bit blurred because I had to take this picture off from my phone. But essentially, you look on the left side of the screen, it measures your extension, which is a quad strength. On the right side is a flexion, and you can see the whole charts. And the big numbers that you really need to see is the fact that her torque, which is her ability to produce power in her quads, are still a massive deficit. The way the Biodex works, there's different degrees where it measures essentially how fast you can pull it and how much resistance that has on you. And at 60 degrees, she has a 32% deficit, meaning she is only 68% on her ACL side compared to her non-ACL side. I'll go to the next page because I'm reading off the numbers right now. At 90 degrees, she's at a 38% deficit, again, a 62% deficit. And lastly, at 180 degrees, which is more for a little bit more endurance based, is she has at this specific point in time, she was 68.7% deficit, meaning she was only 32% of her not ACL leg compared to a non-ACL leg. These are massive, massive numbers that her trainer essentially chose to ignore, which in my opinion is negligent treatment, right? And the reason why I'm sharing this story is because about 4 to 5 games into her season, after coming back from ACL, she ended up tearing her Achilles. So the question is it just because of bad luck, which is sort of what her trainers and things like that told her, or is it because of these numbers that end up playing a role in how her body perceived force and accepted force and her inability to produce power? So like obviously everything's just not even. Again, I can't even say that for a fact, but in my opinion, I think this plays a massive role into why she ended up suffering another season-ending injury. And the question is, like, you know, hypothetically, if she didn't tear her Achilles, let's say she got into her 10th, 11th game of the season, which she had blowing out her other ACL, that's also a reasonable thing that could have happened based on this data that's telling us that she was nowhere near symmetrical quad power. So I'm just rolling through. And again, the reason why this is so personal for me, this is a girl on the right-hand side, a different girl. This girl was a 3-time ACL tear by the time she was a junior in high school. I never worked with her for her first 2. She came to see me for her 3rd one. She drove 2.5 hours of rehab with me once a month. And it was very personal for me because of what she experienced. And she sort of, she shared her story with me about what she went through in the past. And essentially, she was never tested. Every single time, it was very basic rehab, wasn't really pushed in the weight room and things of that nature. And Jordan just told she was scared to go back into playing sports. So she took the advice of these people that she trusted and went back to playing sports and ended up tearing her ACL again and again. And then, so that's what led her parents seeking out sort of additional help. And they came to see me and I tested her like crazy. And there's one day I told you that 90 and above is my gold standard. I will never clear anyone before that. One time she tested at 88 and she asked me if she could be cleared, and I said no. I told her, given her history, it just is not worth the risk. She's been through it too many times, and essentially she was treating this like it was her last time. And this was a very thoughtful test from her. She showed me a picture. She had committed to playing Division I lacrosse and overcame essentially 3 ACL tears, and now she's about a year and a half out from her 3rd one. So she's in a good spot, thankfully. But yeah, this is why this stuff is so important, because it really impacts people's lives. And she had talked to me about like sort of the depression that she went through because she was away from her community, away from her sport that she loved. It really takes a toll on people's lives. And sort of just the basic goals of ACL rehab right here. The goal is essentially to restore full function of the surgical limb. This includes eliminating swelling, full range of motion, strength, which I talked about a lot, power and force production, proprioception, which is essentially your balance and how you control your limb, and confidence is a really big one too, because we know the psychological side is equally as important as the physical side. Some of the return to sport testing is listed right here. So some of that includes isometric quad and hamstring testing. The Biodex, which I told you is still considered the gold standard, but is a resource that is hard to find. Concentric quad testing is super important. Force plates, hop tests, psychological testing, and honestly, even utilizing exercises that you have patients doing as an assessment is super important throughout the entire rehab process. So here's how I use the data. The K delta sort of force plates that we utilize, and then the one on the right is the K push that we use. Sorry, the K pull that we have used for in my clinic that I utilize with my patients. So this is the direct device from Kinvent that I started to use, and I absolutely love it. As you can see, it is charted right in front of you. This is something that I can screenshot and share with the patient, the parents, the coaches, the doctors, anyone in charge of the rehab process, and anyone who's interested. I can show them. As you can tell here, this is the left side is the ACO side, the right side is the non-ACO side, and the data is extremely clear that this patient is not cleared. It shows you the asymmetry on the right-hand side that as far as peak force goes, there's a 28% deficit. So meaning that we still have a good amount of work to do because you want to get that number to be 10% and below. And you can even look at the averages, which is the amount of force they're able to output to the entire duration of the entire push, which for me was 5 seconds. Rate of force development, as you can tell, is a little bit lower as well. Time to max, so it's like how quickly can they get to the peak. And then you can look at the fatigue as well, which is something I need to personally dive into a little bit more. So as you can tell, just based on this data, look at the peak force. This athlete could not get as high on the peak as compared to the ACO side. On top of that, their average is obviously lower. That means that I need to spend more time on this person's quad strength, which was expected at the time. But this just shows, and Alex sort of alluded to the fact that like some patients maybe get like some patients we need to prove to them that they are not ready, right? That's our job as a clinician. It's not about just feeling good and looking good and things like that, which is how unfortunately a lot of people are cleared. This is why you need to have proper testing, because this is not me guessing. I'm not utilizing my hands. No part of this is subjective. This is just the data. I show it to you. Here's the screen on my phone. I can screenshot it. I can export it as a graph, send it to the patient, and they can keep it for their files if they really want to. And the whole premise about this is that, okay, so we tested on this date, and then we go to the rehab process for another 3-4 weeks or so, and then retest again. And hopefully that 28% climbs down to 22%. And then we go to 16% and sort of close that gap. And that's the reality of what ACL rehab looks like. It is a slow and steady climb. There is no shortcuts. There is no magical pill that you take that just magically decreases or improves your symmetry numbers. It's just about hard work and putting the work in the weight room with proper guidance, and just slowly climb and chip away at this thing to get back to full return to sport.
Wesley, question for you. So let's say you have that athlete. 2 questions. One, to just repair you. When do you start testing isometric knee extension? If you have a specific time frame. And 2, what about the athlete that, by the time they're doing squats on a force plate or knee extension, they're obviously squatting. They're probably squatting with some fairly significant, let's say moderate weight. And they feel good squatting. They feel like they're in 50-50. And let's just say their force plate data is, close to that when they're just doing squats. How do you have the conversation with them saying, look, you tested me once. I've been doing these squats my entire life and for the last few weeks, and I feel good. I feel a lot better than a 30% deficit, right? I know it's not you and it is objective, but why would I tie these numbers to how I feel, right? If how I'm feeling is that I can do stairs and then I can squat and I can do things, how do you keep them, one, to buy into that kind of a thought process, and 2, on the other side, if somebody does look pretty good functionally, but you tell them that they have a deficit and all of a sudden they start looking worse, how much of that are we, like, how do you titrate the data to them enough, but not too much? Like, are you doing a psychological sort of assessment of them in your own head to figure out what do they sort of need to get? So one is, how do you kind of prove to them that it is worth it, in fact, even though it's just one snapshot? And 2 is, when do you start taking these, especially knee extension sort of isometric snapshots?
Yeah. So As far as when, I think it does a little bit differ from patient to patient, because I think that especially with a patella tendon graft, we know that they have increased sensitivity in the front of their knee. So I might be a little bit less inclined to do that a little bit earlier, because I don't want to cause irritation to that tendon, especially if they've had a pretty smooth recovery. And in order for someone to give max effort, which is the whole purpose behind the test, that can potentially irritate the tendon. So it is sort of patient specific, but I would say on average, I'm testing at least by month 4 to 5. In that range is pretty normal. Some people test a little bit earlier. Obviously, if there's complications and things of that nature, I don't find it worthwhile to test that for 4 months if they have complications. But again, pending a relatively smooth recovery, I think around that time, month 4 is a pretty good time to start tracking their progress. And in regards to your question about what happens if it doesn't necessarily match up, I think the majority of the time, the testing does sort of show up in the weight room. And I think that I talked about earlier how I shared earlier about the return to sport testing that I utilize. And I mentioned exercise is one of them. Exercise, while is not perfect, I can still show a lot to the patient. For example, let's just say a simple exercise is a lateral step down or a forward eccentric step down. Sometimes I always want them doing exercises on the non-affected limb, because I want them to understand this is what it should feel like, and this is what your ACL side feels like. For example, we have these little 2-inch boxes that we can stack on top of each other. For example, I might have them go on their ACL side and they can only do, we'll say 6 inches, right? So 3 boxes stacked up, and like, hey, let's go try the other side and see what happens. I would say 95% of the time you go to the other side, it's gonna feel easier. Hey, did you realize that your non-ACL side can do 12 inches? That's not a perfectly objective way of showing them, but it shows them that, like, hey, one side can do 12, one side can do 6. That, and I would say most of the time shows them that, like, okay, that's a pretty big difference. And I'll do that across, honestly, almost every single exercise that I have with patients. Whether it's a single leg pistol box squat, oh, you can do 15 pounds on your ACL side. Hey, look, you can do 40 pounds on your non-ACL side. On a knee extension machine, which I really like to utilize. Again, I won't go super heavy until a little bit later. But even your question still refers to people who are 6 months post-op, 7 months post-op, because that's when people, I think that's the danger phase, because a lot of kids they're running again. They may be doing non-contact practices around 7 months and things of that nature. They might be starting to do some drills in the backyard and starting to feel really good. Again, you go to the knee extension machine, which isolates your quad. If your non-ACL side can do 50 single leg reps or 3 reps, and your non-ACL side can only do 40, that's enough data, in my opinion, to show that you are not ready to play. And I often refer to the research articles. Some of them I share with patients, the ones that we're about to go through. I share with patients, I share with their parents, because I want them to understand why I'm making the decisions that I'm making. It's not just based on me sort of being like a lame old PT trying to hold you back any longer than I have to. I tell people, like, I don't want you to end up like me. I don't want you to be part of that statistic. If we have to wait another month, 2 months, whatever it is, but you never have to step in my office again, and you never have to get surgery again, that, in my opinion, is what I deem as successful rehab. So I sort of on a tangent, but does that sort of answer your question?
Yeah, I think that answers it well. I think, we need to get out there the understanding that objective data is important. What form that objective data comes in can certainly vary from patient to patient, but at the end of the day, strength is strength, right? And so if you value the sort of strength to come from a open chain knee extension test, but they may not really see that as a real measure. And even though you may value that, you end up putting them on a knee extension machine and say, look, this is what you can do on one, can't do on the other. That's not the data you're going to necessarily go off of, but that at least thinks in their head. Same thing with leg press. But what objective data is to you and what it is to them, the metrics may change. But at the end of the day, objective data is the name of the game.
Correct. And you're for anyone who is a healthcare provider, you're going to get patients who care about this data, and you're going to get patients who essentially just choose to ignore it because they feel really good. At the end of the day, I can show some people all the data, all the research, show them the numbers, and they may choose to listen to me. And to be honest, I would say 90 to 95% of my patients understand where I'm coming from and will wait to be fully cleared. You get the handful of people who are sort of really eager. The surgeon might clear them. This literally happened to me today or this past week. A patient ignored my numbers. I talked to the mom and the dad and all that kind of stuff. The surgeon was like, oh, she's ready to transition back to what they call like on-field training. So she is no longer in my care. And it's just the reality of how this stuff works. And I gave the whole spiel and lecture to the patient and the parents, but they chose to listen to the doctor who cleared this person early. Is this person at risk for falling under the statistic? 100% this person is, because they never passed all of my tests. Again, the majority of people do listen, which I feel like I can appreciate, because again, I think that because I've been through it twice, they sort of understand where I'm coming from. And by now, I have a pretty good reputation. And also, we share them. People ask like, oh, how many research have you guys had? And thankfully, in my 6-year career here, I've actually only had 2, and both of them were contact injuries. And I'm not sharing that to show off or anything like that. It's just the reality of like I use data to drive my decision-making process, and I will not clear anyone until they pass. I have a high standard of testing, and it's just the way that I've chosen to operate. And I've had people fight back and things of that nature. But this is just what I've sort of set my flag on, and this is how I'm going to work for the rest of my career, unless something magical changes as far as the research goes. Anything else for that topic, Alex?
No, let's rock on.
Cool. So I sort of already talked about this. For the return to sport testing is not just for the end phase. It should be used to track patients along the way, because you need to understand if your testing or if your rehab is essentially making a positive impact on the strength. Sorry, there it is right there. Okay, so we're going to get a little bit into the research articles. I'll try not to bore anybody with this, but I do think this is extremely important to share. So this first article, it's rehabilitation and return to sport testing after ACL reconstruction, where we in 2022, by Gokler, Dingerin, and Tim Hewitt. Essentially, what this came to, I only included this because I found it sort of humorous, is that they basically say that to this day in 2022, and in 2023 now, we still don't have conclusive testing measures as far as a battery of testing. We know that we need a battery of testing, which means that we need multiple different tests, but the battery is different amongst therapists. And even between Alex and I, it might look a little bit different, but I can promise you that the core testings are the same. And that's sort of why I included it. I just thought it was a little bit funny to include. And I do think that this is something that hopefully over the next, who knows, 5 to 10 years, that we are able to get down that, where somewhere people will state that these are the, whatever, 6 to 7 tests that we have to utilize. And I think if we can get to that, plus give people the knowledge and the equipment, I personally think that these re-tear rates will significantly decrease. Hopefully, fingers crossed. Okay, so here's a pretty big article. Simple decision rules to reduce injury risks after ACL reconstruction. This is by the Delaware cohort, by Grindam et al. Essentially, one of the big things that this group found was the fact that every month that you delay going back after beyond 9 months, you are significantly decreased in likelihood. So I'll give a quick rundown. They did 106 athletes who participated in pivoting sports. Of the 55 patients who failed return to sport, which was of the 55 patients who failed to return to sport, 21 of them, which is 38% of the total group, ended up suffering a re-injury. Only 1 of the 18 who passed return to sport suffered a knee re-injury. So that right there is really, really big. 1 of 18 versus 21 of 55. So 38% of patients who did not pass return to sport ended up suffering another knee injury. So they had different qualifications. They included cartilage in there. They can include cell dislocation. Obviously, they included ACLs, meniscus tears, any other re-injury for patients who failed to pass a test was included in this. Of the patients, of the individual components of the return to sport test battery, quad strength deficit prior to returning to level 1 cutting sports was a significant predictor of knee re-injury. And they actually found, which is a number that I often show patients, is that with a 3% reduced re-injury rate for every 1%, 1% point increase in strength symmetry. So sometimes I'll share with patients that 90 and above is the goal, and I think research is now moving towards 95 and above. So for example, sometimes if they're at 87%, based on and this article is that they are 9% more likely, right? So for every percentage point under, you are 3% more likely. So your goal is to try and get, again, as close to symmetry as possible. And ultimately, they found that delaying return to sport is one of the biggest factors as far as safely return to sport. And I think that people sort of misconstrue that it just means waiting. That is not the case. I think that the delaying means that you are obviously rehabbing during that delay, and that will allow you to decrease that symmetry that we're talking about. So that's why sort of delaying is super, super important. And then this next one, ACL reconstruction, rehab, clinical data, biological healing, and criterion-based milestone to inform a return to sport guideline. This is by Brindley et al. And that last name on there, Lynn Snyder-Mackler, is a really, really big name in the ACL world who I really respect, and she does a whole lot of ACL research. So I do value a lot about what she says. So what this found is sort of, there's obviously a lot of words on that page, but basically that last part is the big component. The minimum return to sport criteria should include at least 9 months. Again, this is following up with that last study. Quad symmetry of greater than 90%, greater than 90% on all the hop tests, and also greater than 90% on the subjective tests that they give as well, which is sort of the psychological side as well. Outside the ACLR side, which is stated as 80%. Return to competition should be stepwise, ensuring the patient has achieved pre-injury condition levels and performs maintenance secondary to just essentially continue on the work that they've done despite passing all of the tests. So yeah, that's their return to sport testing, and you'll find that a lot of times, like even with the other ones that are upcoming, that there are differences. But again, the overall strength testing is super important. Hop tests are commonly utilized as well. And one last thing for this study, the failure to objectively measure quad strength may be among the most troubling trends for rehab within the field. So they agree with what I said, was the fact that there's just a lot of places don't have the ability to test. And within the study, they reference Ebert et al. Suggest that nearly 50% of physical therapists do not assess quad strength at all, and as little as 38.5% are utilizing some form of instrument strength testing. And they also mentioned that isokinetic dynamometers have been still considered the gold standard. This is still just summarizing everything that I stated before, is that PT or physical therapists and physios either don't know how to do it, or they don't even have the ability to do it, which are both equally bad. And then the next study, young athletes.
Can I grab you for 1 second?
Sure.
So I think on that point, I was fortunate enough when I was at Hospital of Special Surgery to have a Biodex machine. I think some universities, certainly Delaware, has a Biodex machine, and Biodex type machines, isokinetic machines, are becoming more and more prevalent in larger facilities. However, to your point, one, interpreting Biodex data is not necessarily as easy as, in my opinion, as interpreting isometric data. But with the prevalence of isometric instruments becoming, like obviously Kinvent, but also others, becoming more accessible to small clinics, one man or woman operations, is that, to me, I think it's no longer an excuse, right? I mean, not being able to do it and not knowing how to do it and not being able to have access to it at this point is not an excuse. I mean, it's absolutely ridiculous that we aren't testing at such a high rate, and the fact that we are testing with manual muscle testing, right? If somebody's quad is not able to beat someone else's arm, regardless of the discrepancy in size of therapist to patient, it's a joke, right? And so if the patient is saying they're pushing as hard as they can and they can't break my arm or your arm or my daughter's arm, right, with their quad, that's a problem, right? They're clearly not pushing as hard as they can, because inadvertently they don't want to overpower that therapist for no negative reason, but because they're just meeting their resistance. And that's a lot of time actually what we're talking, meet my resistance. And so, what do you think on that? I mean, would you take a stronger stance on that it's just not acceptable at this point with how accessible technology is and hardware is, to say that, okay, yes, 20 years ago, it was Biodex and KT1000 or bust, but at this point, we can do better.
Alex, I think you and I just became best friends because I 100% agree with you. I think at this point, any facility that sees ACLs and claims that they do ACL rehab should have, at a minimum, a isometric machine to test. You can get them nowadays, and there's so many different blogs and things like that of people essentially putting out information about how to set things up. There's no excuse anymore. And any high, I don't even say high volume, even a low volume facility, I'm going to guess that you can afford to spend $100, $150 on something to test. And I think that any facility that doesn't have that, it sort of shows a lot about, again, their understanding, in a sense, essentially maybe their overall spectrum of what they believe high quality of care is. Because there's way, way, way too much information out there that a facility doesn't have the ability to test. So yeah, I am 100% in agreement with you and would echo that highly. I think when I hear that, I just think that it's very unfortunate because it's ultimately the patients who suffer. Because that therapist just is going to keep going on, do the same thing. That facility's going to keep doing the same thing, and essentially they don't care, in my opinion. So yeah, I definitely agree with you. Okay, sorry, go ahead.
You're good.
Cool. I'm going to go through these last ones just a little bit fast, just so I know that some people may have questions. So this next one, young athletes cleared for sports participation after ACL surgery. How many actually meet the recommended cutoff? So they looked at 150 athletes. They utilized the IKDC single leg. They used the 4 traditional hop tests, single, triple, crossover, and 6-meter timed. And they also looked at quad and hamstring. And they also wanted all 90% or above. And again, the scary statistic in this one is the fact that only 13.9% met all of the return to sport criteria. So what does that mean? That means that the majority of these 150 athletes were put at risk for suffering a second ACL tear or any other type of injury. And then the next one shows, and also, sorry, the one big summary was that those with deficits that return to sports are less likely to maintain their level of sports. Essentially, they phrase it as they're less likely to maintain. Also, on the flip side, means that they're just at risk for suffering another injury. The next one is who passes return to sport tests and which tests are most strongly associated with return to play after ACL surgery by Webster and Feller. It is a prospective longitudinal study that studied 450 patients. They looked at patients at 6 months. They tested patients at 6 months, and they utilized 2 questionnaires, IKDC and the ACL RSI, and also only 3 functional tests. They looked at the single leg hop, triple crossover, and the isokinetic quad strength. And their cutoffs were also 90% for the functional tests, 85% for the IKDC, and 65% for the ACL RSI. And again, the numbers are unfortunately staggering. At the 6-month mark, only 17 people of 450, meaning 3.8% of people passed those numbers at 6 months. And 95% of them, meaning 21%, did not pass any of the tests at 6 months. And the reason why I wanted to put this one out there is because, I know Alex knows this, is that a lot of people are still being cleared at 6 to 7 months. And this is the scary stuff that I think that why I chose to include this article in addition to all the other ones. And then the last one, return to sport tests, prognostic value for re-injury risk after ACL surgery, a systematic review by Ashgibi and Banzer. They looked at 8 studies, which included 6,140 patients were included in the final analysis. It's a really, really big study. Their re-injury rates were a wide range from 1.5 to 37%, so it's a really wide range. And what they found essentially is that there was moderate to high quality evidence supporting finding that a combination of functional tests assesses the risk for subsequent re-injury after ACL surgery. Knee extension strength and hop tests were most commonly utilized across the 8 studies that they found. So just to summarize a little bit, we know that strength testing is extremely important to assess and also utilize across the whole spectrum of ACL rehab. Hop tests are commonly utilized. Obviously within the time spectrum, I didn't want to get into the full nitty gritty of stuff. There's also vertical jumping, which actually has actually been shown to be better for assessing quad strength. But that's when you need to utilize some sort of force plate testing, which I think is even less likely for clinics to have. So I think for now, I sort of stuck with just the strength assessment, which I feel like is a nice place to at least start. So utilizing strength, hop tests, psychological testing, doing those, at least those three things really, really well. And I think, again, show you a lot of data and also show why patients are safe or not safe to return back to sports again.
Awesome. Thank you. So what I'm going to do now is thank you everyone for participating so much, first in the chat and also in the polls. What I'm going to do is go through a couple of the polls overall, because we can see obviously what everyone's at, not by person, but percentage wise. And in general, I think everyone, for the most part, sort of agrees that return to sport testing goes on through the entire spectrum of the rehab. ACL tears and re-tears especially can be incredibly detrimental to what we're doing. And if those two things are true, then why aren't we getting data that we can actually sort of put our foot on and say, this is actual real data, not that's how I felt and how you felt that day. So I think those are the two takeaways, is that if we all feel, the 70 or so of us that are here, feel that's the case, why aren't we sort of screaming this from the rooftop? But that's sort of besides the point, just to sort of go in there. I'm going to give you a couple of quick hitter questions that I want you to try and field. And then we'll get into some stuff I think that will have a discussion. Number one, besides, actually do this. What, if any, specific psychological testing or return to psychological readiness outcome measures do you use? Is it just a conversation, or do you have an outcome measure that you like to use?
I personally use the ACL RSI. It's really short. It's only 12 questions. It asks questions essentially like, are you fearful of returning back to sport? Are you scared of doing pivoting and cutting tasks and things of that nature? And it's a self-graded questionnaire from the scale is 0 to 100, but it's a 10-point scale for each grade.
Mm-hmm.
And the patient, I just have them grade it themselves, and I look at it after. And for me, the reason why it's important to give that is because it opens the door for conversations. And I think that's the biggest thing is, even objectively, maybe they're testing really, really well. Maybe they're testing around 85% and really getting close to that return to sport, but yet they're grading themselves as fearful of returning to sports, right? Something is being missed upon. And we know that as athletes, to be good is to do everything naturally, fluidly, without thinking. That's why athletes are so amazing. But on the flip side, for an ACL patient, despite them testing really well, if they're hesitant to go get that ball or go chase down that person or whatever it is, that's not ideal for returning to sport. So I think that's where it opens the door, just having conversations like, why are you scared of this? Like, what can I do to help you? And that's where having an understanding of exercises, even movement exercises, like, oh yeah, I can help you with that. I can start working on some contact exercise with you within a clinic in a very, safe environment. It's just me and the athlete. I think that's why I like utilizing the ACL RSI.
Thank you. Next question. You mentioned hop test, you mentioned vertical jump, you use a single leg vertical jump. How do you potentially look at those compared to something that's a little bit more technique driven, like pro agility, T-test, 3-cone wheel, things like that?
I think as far as the vertical, I'm looking for, I think the big one is height. I think that what research shows is that your quad is the main one to get you vertically. Again, that's with any test that we do, no single test should be the one clearing you, which is why having a multitude of tests is so important. There is research that, like the traditional hop test, which is more horizontal plane, that is actually more testing your glutes pushing you from point A to point B, but your quads are the main decelerator in that situation. But yet the test is looking at the distance. It's not necessarily looking at the deceleration. So that's my main issue with the horizontal hop test. Do I utilize them? Yes. Do I place a lot of emphasis on them? Not much. But the vertical jump test, I think, is really well correlated as far as testing quad strength. And that's where having some form of force plates is really important, because there's no way to do that with an guy, or you can't tape measure someone if they're jumping vertically. So yeah, that's why I like utilizing the vertical. But again, I do both. I think they're both worthwhile use. Even for the horizontal, I almost use that as more of a psychological test. Are you willing to jump from point A to point B as far as the other one is?
Mhm.
And the first couple of times you do this with patients, it's so evident that they are fearful. They sit there, pause, and think about it for like, 5, 6 seconds, and then they take off. And then their takeoff is slower and they don't jump as far. So it's an easy assessment that you can do pretty frequently. But I don't place a lot of emphasis on the distance. I actually tell patients that I want them to even, not even 90%. I want them to be even, because this is a test that you can easily cheat. If you're going to cheat, you better be 100%. That's at least, again, just, I don't know if anyone shares that opinion, but that's my thoughts on the hop test.
Yeah, I think also, that's where rate of force development comes in, where something that's multi-joint, like a hop test, right? Or a vertical jump might be quad driven, but if you're looking at how fast are you able to produce that force on a vertical jump, there may be more to it, as opposed, like if the peak force is a certain number, that slope may change based on their technique. Whereas if you look at the rate of force development, knee extension, hamstring testing, there's going to be, it's rate of force development, it's there, it's not. And so how quickly they can develop that force, obviously you want to take up the slack in the test, I think is a very useful metric to use. What are you looking for your ratio quad to hamstring?
Yeah, that's a good question. It's something that I definitely need to dive into more. I know there's still mixed data as to like the exact perfect amount. I would say for the most part, I'm trying to be minimum 2-to-1, but ideally even closer to 1.5-to-1 as far as quads to hamstring ratio. I think it's really, really hard, especially coming off from a hamstring graft. It's a different beast when you're coming from hamstring grafts, as hamstring grafts are sort of scary because they can fly through rehab, but then it's that like missing hamstring strength that sort of lingers for 9, 10, 11, 12 months at a time. Yeah, it's definitely something that I personally probably need to dive into a little bit more. I guess what are your thoughts?
Well, I think you also, they're similar. The only difference that I would also look at is the type of athlete you're talking about, right? So one is it predictive of ACL tear that we're looking at, or is it predictive of other concomitant injury that we're looking at, right? Somebody that is not a running or sprinting athlete, how much of that hamstring? What about their age, right? Are they really going back to cutting sports, or they just want to go back to, playing pickleball? Though still a cutting sport, nobody's sprinting. And obviously that's an extreme example, but I would never, I'm never going to take, if a physician were to take a, kind of a middle distance or runner or sprinter and do a hamstring graft on them, one, I think that's a bit of a disservice, but then you're looking at just how slow is that hamstring going to come back? And would you send that person out there, even if everything else did look good, only for the sense that they don't have a hamstring to not pull? Right. And so I think that's my only kind of there. Okay. 2 questions that I think we'll sort of dig a little bit deeper. How often are you pressing if you don't automatically have access to the ATC or the trainer or the coach, how often are you pressing the athlete to get that access early so that you can have it in your pocket in case you sense that there may be a conversation that needs to be had where the athlete may have a mixed message or the parent may have a mixed message? Or do you just sort of say, look, it's up to you. I can only give you the data. You have to figure out whether or not you're going to listen to
it. Again, this sort of is like exactly in the situation that I'm in right now because of all the high school and college level athletes that I work with. There's going to be essentially a lot of chefs in the kitchen. And that's what makes it really, really hard to do with certain athletes. Again, like I mentioned earlier, probably 90-95% of the patients will listen to my opinion and my experience with it, and get the 5 to 10% who sort of don't listen quite as much. So I essentially, for me, day one post-op, or even prehab, testing them for prehab, I am laying my criteria for return sport right away. It's extreme because it's like obviously they're months and months away, but I tell everyone right away, these are the tests that I need you to pass. If you don't pass them, I'm not clearing you. You will never get a letter from me clearing you for return to play. So I established that baseline very, very early. And obviously, if there's trainers involved, especially my college athletes, because they're the ones bouncing back and forth, I still get the same spiel. Because even, for example, if a college athlete tears in March, I'm not going to get them until May, right? So there'll be 2 months post-up by that point. I still give them the same lecture, essentially, because I want everyone to understand where I'm coming from. The flip side is that if you get a trainer or a doctor who clears them at 6-7 months or whatever it may be, which is sort of my patient right now, I tell them that that's obviously perfect within the right. I am not the one clearing you. I just emailed the trainer back literally right before I hopped on this call, I gave them all the numbers. I showed them like, this is why I'm not clearing this. She does not have my clearance. This is why, because she did not pass certain things. She still has pain with X, Y, and Z. She still struggles with A, B, and C. I laid it all out, and that's essentially on them. I think that you sort of have to develop a little bit of thicker skin. If you see a lot of ACL patients, the reality is hopefully people will take your advice and trust your expertise, but there's going to be a handful of people out there who don't care about the data, don't care about the research. And if that's the case, at the end of the day, it's their health. If you did your job as a clinician, you shared the data, you shared the research, and you explained all the facts, and they choose to ignore it, that's enough. If they end up re-tearing or suffering another injury, yeah, you'll feel bad, but you did everything in your job as a clinician, and I just have to, in a sense, be okay with that.
Right, right. Before we get to the last question, there's one other poll that I'd like you guys to consider. Is basically your sort of palette for Kinvent products, and just getting some more information on utilizing the objective measure tools to get some of the data that Wesley spoke about today. So that poll should pop up now. And then the other question that I have for you that I think is very valuable is exactly what you mentioned, right? So you have a patient that's going back to a physician and you've done the testing for them, or their physician, let's say, doesn't want to do open chain knee extension, right? How much of a conversation are you having with that patient to lead them towards, I mean, you can certainly lay the facts out, but are you managing not just their expectations, but the way they deliver the message to the physician so that you don't get into a situation where you're getting mixed signals?
The open chain discussion is always a tricky one, because we do still have a couple in the area that still think that, open chain exercises are the worst thing in the world for ACLs. That's where, again, having research is so important. You share with them the articles that express the amount of stress on the graph and things of that nature, and how it's similar to just walking and stairs and things like that. It definitely gets tricky when you have, especially I would say, more conservative parents who are sort of always following what the surgeons have to say. I thankfully haven't ran into that in my career yet, where someone's so hard pressed on following that rule. So I truthfully don't have an answer as to how I would do that. I think that's so tricky because I personally think that open chain is I don't want to say absolutely necessary, but it's very, very close to being necessary. I also think it's sort of funny because the testing, even if the doctor sends it to a Biodex is an open chain test. So it's sort of funny in that aspect too. Yeah, I personally haven't had too many issues with that so far, but I think that's why I always have all these articles on hand, so that if the case arises, I can show the article. Like, hey, actually, I have had show articles before because the patient will have read something on Google that says, ACL rehab is bad, or sorry, open chain is bad for you. But I share the article with them and I ask them, are you comfortable with me doing this? And even then, I'm still personally pretty conservative. Like I go partial range for about 12 weeks. So I wouldn't go full range for quite a while, just to sort of bridge that gap a little bit also. So it doesn't freak people out that we're trying to go full range at 12 weeks post-op. That's how I sort of navigate the whole open chain discussion.
Awesome. Well, thank you so much, Wesley. This has been awesome. I hope everyone has gotten a ton out of this. I think we've had great discussion. Thank you again, everyone, for the questions, for sure. It's been great. And then we will join us for our next one. Stay tuned. Keep your inboxes open, and we'll have another webinar coming up soon. Thanks, everyone.
Appreciate you having me, Alex.
All right. Thank you.